This is a second session of the Consensus Workshop on Vascular Imaging and CCSVI, the MR imaging session. We have 5 speakers here, and I'm going to ask the speakers to try to keep their presentations to a reasonable level, please, because we've had some wonderful, stimulating discussion afterwards, and it's good to leave us some time to do that. I also want to remind you that tomorrow morning from 8:30 to 10, there are 3 separate sessions, really working groups. So there may be only 20 people in a working group, but one meeting will be here. This will be the session on catheter venography, and then the session on MR imaging will be in the room next door, and the session on ultrasound right beside it. And there will be a handout for you tomorrow with a listing of interesting ideas to get you started in terms of current discussions. And of course, in the ultrasound case, you already have one consensus document, but I guess you will be working on that from what we heard here today. After those breakout meetings, there'll be a coffee break at 10 o'clock, and then we'll all convene back in here again. So that's the only parallel session that we have. And at 10:30, we will continue those discussions with everyone present, so we get a cross-modality type of argument and discussion going on. So the first presentation is MRI CCSVI protocol being presented by Joseph Hewitt. Joseph?
Yeah, it's working. Okay. There we go. Okay, perfect. Well, let's zip through this. I'd like to present to you what we do at our facility in terms of an MRI protocol and perhaps some justifications for why we do what we do. First of all, I have no disclosures, but as you can see, our protocols are quite important, so we want to develop something that's robust and works for everybody. In our facility, MRI is a very integral part of the diagnosis, treatment, and follow-up. And as I mentioned earlier, I really believe that the MRI is very important in terms of stratifying our patient population. Who should we treat? Who shouldn't we treat? Who is going to have a long-lasting outcome? Who may not have a long-lasting outcome? And really being able to give patients some information that helps them rather than, we know that this treatment works for some people and not for others. We use the MRI first and foremost as an anatomic tool to look for a variety of things, including valvular stenosis, flow abnormalities, and other stenoses. We use the 3D contrast enhanced MRV for generalized treatment planning, determining where we're going to access the patient. The nice thing about the 3D contrast enhanced MRV, it gives us a very good picture of the intracranial venous vasculature without having to put a catheter up inside there. Very finely detailed imaging allows us to see subtle vascular malformations. The 3D contrast enhanced MRV portion of our protocol allows us to identify things like collateralization and abnormal valvular stenoses and other anatomic defects in the venous vasculature. The dark blue area at the bottom right points to, we don't have a laser pointer, do we? Oh, okay, great. The valvular stenosis here at the bottom of the right jugular. Here we can see a plethora of collateral veins. Other things we look for instance, are a strong, robust connection between the transverse sinus, the sigmoid sinus, and the jugular vein. Here we see a larger, enhanced image of the valvular stenosis at the bottom of the right jugular vein. And using this information, of course, we can go on to help predict what we're going to do, balloon sizes, the type of angioplasty we're going to use. So that was the subtracted portion of the 3D contrast enhanced MRV. We also use time-resolved 3D contrast enhanced MRV to get a dynamic idea of what's going on in the vasculature. As mentioned previously as well, I think it's really important we get good arterial data. First of all, it helps avoid a lot of unnecessary interventions. It also helps answer a lot of patients who come in and they want to know, is there something wrong with my arteries? Should I be worried about that? The time-resolved MRV also allows us to really tweak out the subtleties in flow at some of the valves. As I mentioned previously, at the bottom of this left jugular vein, we see the contrast filling behind this windsock of a stuck valve, and it gives us a good idea how we're going to proceed with the treatment. In this case, these are the type of valves that we want to use IVUS on in our practice, because we know from some experience that during angiography, if you don't let the angiography go out long enough, you may not see this filling behind the valve. And this, in fact, determines how we're going to angioplasty that valve, knowing that it has that anatomy. Again, using the late delayed phase portion of the time-resolved MRV to see valvular pathology. 2D time of flight. This is also very useful to us in our practice. It's one thing to have a picture, but it's another to have a very good visual representation of the flow. It gives us idea where there's jetting. The banding, of course, can be due to obstructed flow at the valve. Can also be due to some circular flow. Also gives us a very good idea what sort of flow we're seeing in the collateral vasculature. Again, on your left side, this is really a pretty picture. It's one of my favorites, where we see in this image, we know that the valve anatomy is restrictive, so to speak, and over here we see the flow result of a restrictive pathology at the valve, a jetting phenomenon. Very useful 2D time of flight. We want to enumerate the flow abnormalities so that we have a standard by which to judge the flow. We know through doing a lot of these some relative values of what we feel is normal and abnormal, and also so that we can document a flow so that at some future point we have a reference value. Part of our protocol as well is some significant imaging of the azygos vein. Here you see an oblique sagittal image, as well as some axial images demonstrating stenosis of the azygos vein. And this allows us, in our practice at least, to talk with patients about the possibility of using an azygos stent. This is the only place in our practice where we use stents, and it's very useful to us to be able to have a meaningful discussion like that beforehand. Of course, being able to look at it in 3 dimensions is also useful. We found that the azygos vein can often vary in size and apparent stenosis with respiration. By looking at it in 3 dimensions, we can sometimes see this ahead of time. Quantifying the azygos vein flow empirically is also an important part of our protocol. Again, we have values below which we have a higher likelihood of doing an intervention on the azygos vein. We put all these data points together, the 2D time of flight, the visual imaging, the empiric flow, and it sort of directs us towards what branch of our algorithmic treatment tree we're going to follow. Again, another slide from earlier. We use vibe imaging now to also take pictures of the azygos vein and the renal veins. And although it adds more work, we're having to look at more organs, we're having to look at more potential pathology, it's just very useful to us to be able to get a good anatomic image of possible venous pathology before we have to deal with it. And quite frankly, the patients are very interested in this, seeing the venous pathology before we get them in the room. We do a lot of CSF flow characterization as well. We're very interested in that, and I'm sure that Raj is going to talk to us later on. I think this may be, in the months and years to come, a very interesting part of our analysis. We've looked at the flow out of the structured cranial vault through the veins, but the whole idea of CSF flow as another outlet for this transmitted energy from the arterial vasculature entering this non-compressible vault of our skull in the form of CSF flow, I think has been neglected to this point and will show some very interesting results in the future. So we use phase contrast imaging with normal biphasic flow, where we have caudate flow corresponding to an arterial pulse entering this non-compressible, non-expandable, relatively cranial structure, and cranial flow corresponding to venous outflow, where we see a positive reflection. The patients, of course, always want to see their their lesions. They're all caught up with their lesions, and I don't blame them necessarily. So we try and enhance that experience by analyzing the lesions, showing the iron deposition, and being able to track that over time. We're also looking at iron deposition in the deep structures of the brain, caudate nucleus, red nucleus, substantia nigra. We've started in the last little while doing perfusion imaging. We're very interested in doing perfusion imaging, starting with region mapping, cerebral blood flow, cerebral blood volume, and mean transit time. Of course, quantifying all this for future reference. We're also starting to do some diffusion tensor imaging. We're embarking on a study we started about a month ago called our Verify MS study. In my mind, there's two big questions that I'd like to answer. The first is, I guess I'd start with the second point here. We hear a lot of feedback telling us that the incidence of CCSVI in patients with MS is not significantly different, or is not monumentally different, let's say, than controls. So every patient that comes to us who has not had the procedure before, we're doing the Hakey MRI, MRV, and we're also doing it on their non-blood related spouse, partner, family member. Up to this point, I believe we've probably done about 30 people. I'm shooting for about 300 or 400. And hopefully we'll get a good, robust study comparing MS patients with controls, perhaps a small piece of Mark's Millennium Project. One of the second big questions we want to answer is about the placebo question. You'll hear this from a lot of the neurologists, that it's just a placebo. And my way of analyzing that in this Verify MS study, we're going to be doing the Hakey MRI beforehand, and we're also doing it after the treatment while they're still with us in California, looking at flow and perfusion. And perfusion in particular, I'm very interested in seeing the changes in a large number of people, several hundred, like I've stated. So we're doing this, and this study should be done hopefully by this time next year, and we'll have something to present in Krakow, I hope. Part of our protocol is follow-up imaging. If I had my druthers, I'd have everyone get some imaging, a Hakey MRI once a year, some sort of an imaging protocol where we can assess differences in flow, if there are any, in CSF flow, in venous flow, in perfusion, and really be able to talk to our patients in a meaningful manner when their symptoms change relative to hard data. So in summary, we use time-resolved 3D MRV, subtracted MRV, 2D time of flight, jugular and venous imaging, jugular and azygous imaging, excuse me. Of course, we empiricize and numericize all of our flow so that we have structured data to make algorithmic judgments about and to have reference in the future. Lesion characterization with iron and also with perfusion imaging. Iron load, we're interested in looking at that and how that changes over time relative to disease progression and symptom development. We're starting to do diffusion tensor imaging. Getting a rough idea of renal vein and azygous anatomy with vibe imaging, whole body. And part of our protocol, of course, is the follow-up imaging, and we're working also on a patient-friendly report summary. I spend a lot of time, probably every MRI that I do, I spend about 45 minutes on the phone talking to the patient about their report. And there are certain things I pick out of it, and I think we're working our way towards a simple summary that patients can walk away with where they stand to relative norms. It says Igor, he's responsible for enforcing the new MRI protocols. I guess that would be me. Thank you very much.
All right, any questions for Dr. Hewitt? I know that Zeev Haskell had asked me a question about reducing the time it takes to apply this protocol. Joseph, you're doing so many things on here, it must take you somewhere around an hour and a half to 2 hours to be able to do all of these things. Is it possible to be able to do something like this in a clinical environment where you can cut back on a number of these research items, and what do you think the importance of that is, or should we just stick with doing research protocols at this point?
I think you're going to eventually end up with a two-tiered system.
And that's not to mean a two-tiered system in terms of quality. I think it's a two-tiered system in terms of expediency and efficacy. I think there will be sites where we do the full research protocol, which I think right now is about 80 or 90 minutes. Surprisingly, most patients don't seem to mind. In fact, I can't recall a single patient who, after they were shown the results, minded being in the magnet for that long. Certainly in your typical hospital environment or your typical imaging center across the country, you know, for economic and logistical reasons, I can't see them doing 80 or 90-minute studies. And so I think we're going to take a crack at this tomorrow, trying to perhaps present something to your typical imaging center or hospital-based radiologist that can be compressed into perhaps half that time.
Thank you very much. Yes, Sandy.
How have you found your correlate between your MRI study and your venous study when you're looking at the azygos? Because I think at a previous meeting I was at, Mark specifically said that we were having trouble assessing the azygos with MRI because of the respiratory variation and artifact produced by that. So have you got a pretty good correlate, or is there still room for progress?
There's still room for progress, certainly. You know, in the upper portion of the azygos, around the hook of the azygos, there's a lot of valvular pathology that we really can't assess well with the MRI. But I have to be honest with you, if you look at enough of these, and I guess I've looked at, I don't know, I've probably looked at 800 or 900, maybe 1,000 of them, you start to get a feeling when you look at the stenoses, when you look at the flow rates, when you look at the size of the azygos, when you look at the collateralization. And I think it's meaningful when you can synthesize a number of these factors and be able to speak to the patients about relative likelihoods during the procedure.
All right, thank you very much, Joseph. We're going to go on to the next presentation, morphological MRV multimodal studies in CCSVI. And Dr. Svadinov is going to give us a little bit of a combination now between MR and other modalities. Robert?
Thank you very much, Mark. Can I have my slides? That would be nice. So what I'm going to try to do is a little bit a different story, because I don't share some of the opinions with you. And I think that MRI is definitely challenging at the moment to be done. They are saying to me I should try to find the slides here. But Zivadinov, that's me. Okay. Okay. So these are my disclosures regarding the CCSVI as well as other work that I'm involved with multiple sclerosis and other diseases. So as you know, there are different modalities that we can use for making diagnosis of CCSVI, the non-invasive and invasive, Doppler sonography, MRI, CTV, and invasive catheter venography and intraluminal ultrasound. So basically, a lot of papers have been published. Not many are multimodal, and only by using multimodal papers in which, with invasive and non-invasive imaging, in which we include healthy controls and MS patients, we will be able to answer some of the questions that we are posing today, and this is how sensitive and specific are all these imaging techniques for detection of the CCSVI. So our experience is clearly, I would say, long. We started a couple of years ago, immediately after we started our collaboration with Professor Zamboni, and now maybe we are, I don't know in which study, but the premise which you see on this screen is probably the most challenging endeavor we ever embarked to. It's a study that's using 5 imaging techniques to determine the same point, which is there a problem with certain segment of the vein, whether it's MRI, TOFs or tricks, or whether it's Doppler or computer tomography, or intraluminal ultrasound and catheter venography. So we are preparing our paper at the moment on 30 subjects who obtained these 5 procedures, and we will know how these measures are overlapping in terms of sensitivity and specificity. So what I said on the patient program is, and I'm saying here too, is, okay, what the CCSVI is made of. And one thing is that these intraluminal abnormalities are inside the veins. We can classify them as web, flaps, septums, membranes, malformed valves. You saw this slide before. And with all honesty, I do not think that any imaging technique in terms of MRI and computer tomography can characterize with good reproducibility these abnormalities. And we tried a lot. We did reproducibility studies. We are not able to image these abnormalities on a 3 Tesla state-of-the-art scanner. And I think that Doppler is much better for characterizing these abnormalities. Moreover, many healthy people have these abnormalities too. What MRI is good is in finding this stenosis. And this is kind of very important because you would see later that sensitivity and specificity in finding this stenosis is pretty high with MRV. What MRI is also good at is finding collaterals, but certainly not imaging functional changes like reflux or paradox or no flow. So respect to the collaterals, I think that it's much superior than the Doppler. So if these are the CCSVI abnormalities, you know, can we confirm them on histopathological findings? And you just heard from Karen before that in this histopathological study by the Cleveland Clinic Group that hopefully we will be able to hear on this meeting, they found much more intraluminal abnormalities in comparison to extraluminal abnormalities between MS patients and healthy controls. That means that stenosis are pretty similar post-mortem in MS patients and controls, but what is really different are these intraluminal abnormalities. Now, we don't know at this moment what's the origin of these abnormalities. Could be really aging-related, inflammation-related, virus-related. We just don't know. So with this very short background, I'm going now to start on what is my task, and that is MRI per se. So I'm going to speak only about the magnetic resonance venography. So there are conventional and non-conventional MRV techniques. The 2 techniques that are conventional are 3D time resolved image of contrast kinetics, as you heard, and 2D time of flight. The non-conventional MRV techniques include phase contrast MRV and multidirectional TOF. Buffalo approach in all our morphological studies, which have been done on a 3 Tesla, included assessment of jugular vein flow morphology in inferior and superior segment, and by characterizing on a morphological scale the pathologic flow, which we characterized as absent or pinpoint. All other flows like flattened, presenting, and ellipsoidal are what we see very, very commonly in healthy people. The vertebral flow can be absent or present, and clearly we are evaluating number of collaterals, type of collaterals, etc. We used in all studies 2 independent neuroradiologists. The first study that we published last year in radiology is a study that included 57 MS patients and 21 healthy controls. We compared with this morphological scale and found no differences on the TOFs and on tricks. Although you can see that there were more pinpoint jugular veins in MS patients, both on TOF and on TRIX. Now, one thing was clearly written in the paper that this could be also dependent to the power sample of the study, but the first MRI paper we published was negative. So in the second paper with Professor Zamboni, we asked ourselves another question. Let's do catheter venography on 10 MS patients and 6 healthy controls. Let's do the Doppler and MRVs, and let's find what's the specificity and sensitivity. So in this study, we found very high sensitivity of the MRI techniques, but very low specificity. That might be due to the fact that clearly some of the stenosis that we were saying were really not reflective of what is on catheter venography. Doppler had much better values. Just that clearly led us both in the radiology and in this study to perform some reproducibility results, putting the same healthy control or MS patients twice in the scanner. And we have many cases in which there is a clear pathology on Doppler, but if you look the jugular veins, they look perfectly normal. And if you look the catheter venography, it's altered. This is a follow-up after 6 months, and after angioplasty has been done, and MRV looks very similar, and Doppler in this case was normal after 6 months. This is another case in which MRV is completely normal, Doppler abnormal, catheter venography abnormal. After 6 months, again MRV normal and Doppler normal. So then we clearly did studies on healthy controls, and we published that in both International Angiology and AGNR, where we looked on these healthy controls with catheter venography after a period of time. In this case is 6 months, and you can see that that jugular vein, which was perfect, fully loaded with blood, now looks completely stenotic. And clearly the Doppler tells you that this is not the case. So I have definitely a concern that, and you will see what I'm going to show you now, that MRI has false positives and false negatives. And I'm not saying that Doppler does not have, but MRI definitely has. Now this paper has been published on a cervical part by Dr. Day group, and they are saying that it's another multimodal paper. So in total, as you saw from my blue and red slide, there are not more than 7 papers which are multimodal at the moment in MS. And he found a sensitivity and specificity of 79 and 76 in the cervical venous system. He also found poor kappa for agreement on collaterals. So this is telling us that maybe at a different level in the cervical venous system, the MRI may be more useful to identify those stenosis. Now, then we embarked on a study that really looked on intra-extraluminal and functional venous anomalies. And look the case when there is a huge difference between cases and controls. This was a study of 150 MS patients and 63 healthy controls. And when you look intraluminal abnormalities, there is a huge difference. But when you look on Doppler, extraluminal abnormalities, that means significant stenosis, something that Karen spoke about before, you find a trend for differences between MS patients and healthy controls, much more between progressive and non-progressive patients. Take into account that progressive patients are always about 10 to 15 years older. Now, this is something that I want you to remember, because huge differences in intraluminal abnormalities, very little or no differences in extraluminal abnormalities. So in this study that had triple sample size of the radiology paper, so now we have 150 people with MS and 63 healthy controls, we still do not find differences between MS patients and healthy controls in extraluminal abnormalities, which are stenosis. There are huge differences both on TOF and TRICS between progressive and non-progressive patients. We found a trend for higher number of collateral veins in MS patients respect to controls, 2.6 versus 2.1. There were no differences in number of collateral veins between progressive and non-progressive patients, and I think this is extremely important. There was a good correlation between number of intraluminal abnormalities and number of collateral veins on TRICS and TOFs, which is telling you that there is some anomaly flow problem. This is a paper that you can find in your prints from at this conference. And what we asked in this study was, okay, what's the specificity and sensitivity of Doppler versus MRI individually, and when you combine them in to make what Joseph was referring to help us make diagnosis of CCSVI. So if you look at the sensitivity, and this is criterion 1, 2, 3, 4, 5, 2 criteria of Zamboni, 1 criteria of Zamboni, just the jugular vein criteria, just the vertebral vein criteria, you can see that they are between, the best is really the 2 VH criteria, around 64%, with a specificity of about 86%. Now, all others have maybe higher somewhat specificity, but the sensitivity is very low. Now, if you look for MRI, MRI definitely has much lower sensitivity. In all studies we did, we never find between more than 30% of patients to have extraluminal abnormalities, but also 24% of healthy controls have them. Only progressive patients have more respect to the non-progressive ones. Now, if you look in number of collaterals, presence of collaterals is definitely not very good, but when you look number of patients who have 1, 2, 3 or more collaterals, you begin to see the changes between patients and controls. And so we asked a question which is, okay, what if you combine MRI and ultrasound together? And if you have 1 Doppler criteria of the jugular vein and 1 abnormal criteria on MRV of the jugular vein, specificity is 84%, but only 28% of people have that. So sensitivity very low. If you have vertebral criteria with MRV vertebral, again, huge specificity, but sensitivity is low. Now, if you have jugular Doppler and criterion 2, which is the reflux in the brain, and you add another collateral, it has almost 40% of patients have that versus none of healthy controls, and with an acceptable specificity of 81%. And then you can go to the 95% or over 90 specificity, but number of people who are going to match all these criteria are going to be very low. So this study suggests that conventional MRV could be complementary in detecting extracranial venous anomalies with, however, lower sensitivity and higher specificity. Now, obviously, we are not the only ones who publish studies on MRI or MRV. Sundström published a flow study in which he did not find in 21 MS patients and 21 healthy controls a difference in MRV flow. There was a trend for lower cerebral blood flow in MS patients, and 3 MS patients presented stenosis on interjugular veins. Group from Amsterdam published another paper in 20 MS patients and 20 controls, and 10 MS patients and 8 healthy controls presented these extraluminal abnormalities. Another paper appeared in Neurology, 40 MS patients, 12 had 30% of stenosis on MRI, 30% had 0 to 50% narrowing, 19 patients, which is 48, between 50 and 80, and only 4 patients more than 80. By ultrasound criteria, they found only 4 patients had this, but we have to be very careful here because in the previous study they said none. Now they are saying, hey, there is so much more on MRI. And they found that those people who had more than 80% of stenosis respect to those between 0 and 50, there was significantly lower flow in those with higher stenosis. This is a very interesting paper that appeared in Multiple Sclerosis last year. 27 MS patients, 26 migraine patients, and 27 healthy controls. Venous outflow was significantly increased in MS patients compared to healthy controls, but identical alterations have been found between migraine patients and healthy controls, significantly more in migraine than in healthy controls, and there were no significant differences between MS patients and migraine. You may have seen in AGNR another paper on positional MRV. We made a comment to this paper recently because they did not take into account that when you get in upright position, most of the flow in the jugular vein probably is not going to remain. Then we have Dr. Haki paper of 200 patients in which 136, almost 70%, showed IGV abnormalities and the rest did not. So the flow was different in those with stenosis and without stenosis. So MRV morphological studies, I think, showed that there is a higher specificity for diagnosis of MS than with Doppler, but lower sensitivity, and it's also depending on the location. I think that MRV flow studies definitely show that there is no normative data at this time available. I think that control studies did not show differences between MS patients and controls. There are significant differences in 2 studies, as you saw between morphological stenosis and non-stenosis, and this, I think, posed a question: can we apply for low values on individual subject basis for detection of the CCSVI? I don't think so. What are the advantages and disadvantages of MRI for CCSVI? This is my summary slide. I think it's non-invasive, can easily depict intra and extracranial venous system. Blinding procedures are easy. Flow velocity studies, as Joseph pointed, can help us, but I don't think we can take them as fact to make any treatment decision. And clearly is acquired in a very tiny slice resolution and can acquire head and neck. The disadvantages are that, in my view, imaging of the azygos is impossible, that it does not recognize intraluminal abnormalities. It suffers from positioning respect to the nearby structures, swallowing, respiratory phases. It has low resolution for vessel wall determination and can provide false positive and negatives. However, it can help us, together with Doppler, to make the decision, especially in respect to collaterals, because you saw from my functional neurology paper that the only variable that added to the value of sensitivity and specificity of Doppler were the collaterals, nothing else. So I think that collaterals are probably one important thing that we can take from the MRI or MRV in order to put together with the Doppler in order to make better screening for the CCSVI. Thank you.
Thank you very much, Robert. That's a lot of interesting material. I think one of the things I just wanted to mention that today some of the MR techniques that we're using, just to give the young people and the students in the audience something to think about, are in fact much lower resolution and much slower than are going to be possible even in the next few years. I saw at a cardiovascular meeting recently MR data acquired in 64 milliseconds in real time, so there was no need to cardiac gate, no need to respiratory gate. And so I think things down the road will come along that will make imaging the azygos quite viable. But the real question is what's happening when you see something different in MR or even if you image the same patient a week later or a month later and get something different. I'm going to throw something on the table for you here that if you see it's different in MR, it means it really is different. And if it's different a month later or a year later, then it may be physical compression, it may be something changed in the patient. And if you were to do both angioplasty or if you were to do ultrasound and compare them, if the MR has changed, the odds are you're going to find so have those other modalities changed. Because MR basically doesn't create the anatomies that are there, it simply gives you a picture. So it's okay that they're different, but that means they probably are different. So I'm not sure that's a negative thing. I think it says that maybe you can't evaluate the same patient a month later because he's changed. And the question is, would that be true with PTA? Would that be true with ultrasound? So that's just kind of my comment here on what you're showing.
Clearly our goal is to, with this consensus too, to come up with criteria that may help us to identify those patients with MS or with other conditions that are appropriate to go to the invasive diagnostic procedure. Whether it's just the procedure or it's treatment related to that, it's another question. Now, clearly, I think that by combining MRI with the Doppler ultrasound in trained hands, you probably achieve, as you see, higher specificity, almost 90% and over, but you are decreasing amount of people who are going to be eligible to go to proceed with the invasive diagnostics. In our hands, as you can see, not more than 40% of the people would be eligible to go and get the catheter venography or ultrasound. Now, but based on these studies, these 40% of people will definitely have something on catheter venography on IVUS. Now, clearly, we can increase the sensitivity, but you are going to lose specificity. And whether flow studies, we are doing flow studies simultaneously on Doppler and on MRI. So we will soon have data on over 200 people between MS patients and healthy controls, how the flow values in terms of milliliters per second are to be compared between two different modalities, and can they help us, to identify patients on individual basis. I'm sure there will be great, maybe differences in groups, but that's not the question here, because the question is how you apply that on individual subject basis. And clearly, having one collateral, as I showed, and we had done this in a number of studies now, is not a criteria, to be alarmed, because many 95% of healthy people have one collateral. So down the road, we also, looked at computer tomography as much more promising for a zygous vein than MRV, and I can unofficially tell you that these beautiful pictures from computer tomography do not match what IVUS or catheter venography is showing on these patients. So I think that multimodal is only way to go. The best we can do at the moment is to combine Doppler and MRI together.
Great, thank you. I do want to give Jerry an opportunity to ask his question here, but I will just make one comment. We've imaged hundreds of people for the azygos vein, and we're not all the time, but most of the time we get very good azygos vein data. So it's possible to do it in MR, but as you say, the question is whether it really correlates with the PTA or not. So Jerry, you've been waiting patiently there, yes?
Just two questions. One, were you finding any MRI abnormalities and correlating them with, for instance, quality of life or severity of symptomatology and seeing a correlation there? And number two, if you were going to design a study and have patient enrollment to demonstrate efficacy of a procedure like angioplasty, what would be your criteria as a definition of CCSVI? So if you did multimodality or just MR or just ultrasound, what is going to qualify a patient for entrance into that study?
So the first question is, we have many papers that are dealing with association of CCSVI with MRI. We are looking on the quality of life too in this placebo-controlled trial premise that we are doing in Buffalo. For the sake of the time, I can't go through these studies. In terms of the second question, we believe that both doing MRI as well as Doppler should be done in all those who are having the procedures and trying to understand how they are doing. Obviously, some things are very clear, and don't misunderstand me. We have had experience in premise as well as in study with Professor Zamboni that when both techniques are showing very same thing, you are very, very confident that the stenosis reoccurred. I think that both imaging modalities are needed.
What criteria in ultrasound and what criteria in MR would be, if you have these three items, you're in the study, or if you don't have these two items?
So in previous studies and in the premise, we are having a criteria. With Dr. Zamboni, we had a criteria of having, again, two CCSVI criteria on Doppler. In the study we are doing now in Buffalo premise, we have a criteria for stenosis of particular segment that patient underwent the treatment on. So let's say if you have a intraluminal abnormalities or a stenosis in the internal jugular vein and you repeat Doppler and you see exactly the same picture, that would constitute of having the same problem. Now, in terms of percentages, we are not in favor of grading more than 50%, less than 15% of lumen, because I think it changes a lot depending on the where you are looking at in the jugular vein.
All right, last question.
I very much enjoyed your presentation. To me, you've given us a very important message, the presence of collaterals. Now, when we're doing ultrasound, we're not specifically looking for collaterals, but sometimes we see them. And my question is, if we concentrate and search for collaterals on ultrasound, do you think we have a chance to improve the results of ultrasound?
No, you are losing time. Because we tried, and the problem is very much also respect to what Karen spoke with before, how you evaluate collaterals, respect where these collaterals are entering. We didn't find good reproducibility of our RVTs. In finding collaterals. I think it's much cheaper, easier, and more robust to do that with the MRV than doing it with Doppler.
Ray Robert, thank you very much. Is Mike here? Oh, there he is. Okay. Mike, you're up. So Mike, as you know, is had a lot of experience, not just in terms of looking at treatment of patients. He's been focusing also on flow quantification. And I think that the direction of flow quantification, especially in 3 dimensions, if we can get there and do this fast enough, is going to provide the people in computational fluid dynamics with exactly the tools they need to be able to predict what the effects are of abnormal vasculature. And Mike, looking forward to your talk.
Thanks, Mark. And I'd like to echo the last speaker and congratulate Robert on that. He gave us a very valuable analysis based on that comprehensive review of a lot of instructive details. I'm going to be a little more subjective. I'm going to set it up for Mark, who is going to be analytic, I guess, on some of the flow things. And I'll give you sort of a works in progress, or at least what we're doing at Stanford right now in terms of trying to get at some of the physiology. These are my disclosures. I don't believe any are relevant to this talk or CCSVI. And I put in here just some background sort of observations. Again, we're all sort of challenged by this puzzle of CCSVI and trying to put together individual pieces to sort of build out something until we can see an ultimate picture that we hopefully will provide insight and understanding. But right now we're sort of left with individual mosaics. So I just thought I'd throw these in as a start. And this is the first, and obviously this is just one study, but it's well recognized that diffuse hyperperfusion precedes development of MS plaques. And certainly it's been shown that in normal appearing white matter, this hypoperfusion exists, and your disease state or how progressed your MS is associated with lower cerebral blood flow and cerebral blood volumes. And this was shown in this study looking at the progressive, primary progressive on the right compared to control and relapsing remitting, again with much lower blood flow signals as we get more progressive. Again, another piece, hypoperfusion could be related to a number of things. It could be related to ischemia, but it could also be related to tissue degeneration or degradation, Wallerian degeneration, etc. And this study and others, again, have sort of shown that more than likely based on MR studies that at least in this study, 14 patients with relapsing remitting, it was clear that in their minds that this was truly related to ischemia, not Wallerian degeneration. If you looked at the diffusion tensor imaging and perfusion changes were much more consistent with what we expected in primary ischemia than in secondary hypoperfusion from Wallerian degeneration. And then finally, again, we can see here hypoperfusion correlates with the degree of venous hemodynamic insufficiency, severity score, or in other words, the progression of CCSVI. The higher or the more stenoses you have, the more likely you're going to have hypoperfusion. And finally, from Robert's group, the more extracranial venous stenoses, or the higher the CCSVI severity, the more significantly decreased parenchymal venous vasculature. So all this provides us with sort of, again, some very rich and very, I think, tantalizing pieces of the puzzle, which we haven't yet been able to put it all together. One of the reasons is when we're treating CCSVI, or we're at least in that position of looking at these non-invasive studies and deciding whether we're going to treat, how do we know if the venous lesion is significant? And that sort of gets to what, I'll just say it a different way, but I think a lot of people have said this already, but there's sort of a general acknowledgement now that anatomic renderings alone are just grossly insufficient. They're limited and often inadequate indicators of the venous disease, and as you go through all the potential candidate modalities for imaging, and I think that's why we're all talking about, putting together imaging rather than a single be-all, end-all study. If you look at CT and MRV, obviously, as Robert showed you, there are high false positive, high false negative rates. Ultrasound certainly our best modality for identifying intraluminal lesions, but clearly it's operator dependent, it's time intense, it's hard to blind operators, it depends on all these different criteria that we still haven't really, I think, finalized on. And then catheter venography, besides being invasive, is, I think, kind of a tarnished gold standard, even though that's what we rely on ultimately. But again, lesions can vary with position, respiration, muscle contraction. We can't really evaluate the valve with catheter venography alone. We'll often use IVUS, but in any event, it just shows you that we need something beyond anatomy if we're going to feel a little more secure and confident in moving forward, and I guess that's physiology. there's this emerging recognition that's critical. We understand what the relevance physiologically of these lesions or anatomic narrowings we see. And so what are some of the ways we can do that? Well, I'm just going to show you what we do, and that is looking at MRI flow quantification and measurements to quantify flow. Early on, we obviously thought this would be valuable, and again, we do have some good expertise at Stanford in MR. So we do 4D flow on all patients. The whole exam that includes the 4D flow for these patients, we have to keep at an hour. We don't ever go over an hour just for other reasons, but I won't go into that. But now we sort of look at J1, J2, J3, high, mid, and low jugular. We do flow rates at each segmentation. Their time point in the heartbeat were calculated, and then they're presented as time-varying flow rate waveforms and average flow rates within each jugular. And this is just an example of what could be done. And you can see, obviously, a degree of phasicity and pulsatility going from the highest amplitude, which is low in the jugular vein, to down to the yellows at the bottom, which are obviously somewhat dampened and represent transverse sinus flow waveforms. And we also thought initially going in that we could get some signature profiles, that if we saw these waveforms, could we sort of sort them like baseball cards or stamp collections and sort of put people in different groups. And that, unfortunately, hasn't worked out very well. So that it doesn't mean there isn't still potential to do better, but it's what we've really found, and I think I'm interested to see what Mark's going to say, is the most compelling factor to us where we really saw the best segmentation between patients with CCSVI and those without. And it's not perfect. There's not a line that says everyone here is this and everyone here is that. There's overlap, and there's some rather striking cases of where MS patients do not have low flow rates, and patients who are normal have very low flow rates. But in general, the thing that really to us that we look at now in all patients is basically what the average flow is in each jugular. And anything that's below 0.2 liters per minute we consider distinctly abnormal, and almost always, again, gets our attention to go ahead and do venography. So again, I'm going to try and get us back on time too, because we're a little over here. Here again, we look at these waveforms, pulsatility, amplitude. We only again look at 3. In this case, we looked at 4, but basically these are in the proper form. Sometimes you see flows, say at the mid, or a pulsatility in the mid, with an amplitude that's greater than it should be down low. That's not normal. But in this case, there's the normal sequence of going up successively from high up in the jugular up to the higher amplitudes, which are low down in the jugular. But if you look at the axis, these are very low flow rates. And that, again, gets our attention. If we look at this patient, again, and this is kind of some of the, again, sort of primitive richness that we liked, and now we've got the flows and we've got the images, and we can sort of correlate, and that at least gives us something to do. And what we see here, again, is looking at these and then comparing it with the flows. You can see the right internal jugular, very low flow rates, and the left even lower, except for down low. So this is what we're looking at now. We find this valuable. I don't think we've done enough, and certainly nowhere near as much as Mark has done, and will share with you, I'm sure. But the real question is, where are we going? And I think that the only way to go forward is, of course, to do what we're doing here today, and that's collaborate, working together, try and get at what seems like promising leads, to get on the string and follow it, but be ever mindful that right now we still don't know as much as we don't know. Thank you.
Thank you, Mike. Any questions from the audience? Mike, in the data that you showed for the 3D and the time-resolved 3D, do you have any results comparing that with computational fluid dynamics at this point?
No.
No.
We're starting to do that. We're getting more and more people interested in, and again, it sort of builds, you know. At first you have just the real sort of people who are engaged, but now we're starting to broaden out to people who have special skills. We're looking at, well, you know, Brian, myelin mapping now, which is very interesting, but we're going to start to look at some, we have good computational fluid dynamic people to look at.
What about the role of CSF in doing these computational fluid dynamics calculations?
We're aware of the work that's gone on, but we haven't done any of it.
All right, thank you.
Next up is Dr. Mark Kakey out of Detroit, Wayne State University, MRI Innovations. And Dr. Hakey is going to be talking to us today about MS MRI database. Dr. Hakey. Okay, yep. So it's on.
All right. Higher here. Mike, I'm sorry you're going to have to wait till Tuesday for that presentation, but your last slide was really a perfect lead-in to what I wanted to talk about here. And also, I'll be fairly brief with this. I think this point of collaboration is really just perfect for today. We have the capability today to transfer data from one site to the other very easily. Many of us are using the same type of equipment. We're trying to get standardized protocols from which we can share things. And so I think it's really important at this point for us to look at designing an international MS, MRI, and perhaps ultrasound and also PTA and other things, but I'm going to focus on the MRI part. As far as my potential conflict of interest, I'm a member of a number of universities. I have grant support from Siemens and NIH, and I have interest in MR innovations. So I want to start by a quote specifically for the MS population. It's based on a paper, a technical paper that has this quote at the end of it, which is very interesting. It's about doing sympathectomies. In the 1930s, people thought that MS did have a vascular component, and they specifically thought that maybe it was coming from vasospasm. So there were a few groups there that were actually doing these sympathectomies, and that's a pretty major operation. And they had just about the same type of contentious response from the neurologist. But a very famous neurologist from Chicago, George B. Hassin, who didn't really believe in this particularly, still said the following: multiple sclerosis is such a distressing, hopeless condition that any therapeutic measure that appears promising should be given careful consideration, regardless of the difference of opinion as to the pathophysiological features of the disease. So we can't be biased. Modern neurologists should pay attention to what Dr. Hassin said, and we obviously have a lot of technical things that we need to investigate. And we're all probing things at the moment with some interesting technical quantifications here and another little bit there, but really we need to stop poking the elephant with a pin and start looking at it as an elephant. So the goal is to compare results from various labs, to ensure similarity of results, to provide a data mining capability. It's nice that we have papers that have 50 cases here or 100 cases there, but we need papers that are doing 1,000 cases or 10,000 cases. We have that capability today because many of us have very similar pieces of equipment. We know roughly 20 people who have 3T Siemens scanners, and we probably know 10 different sites that have 3T GE scanners. So it's possible to bring those people together. So to generate the potential for improving the current technology is also very important. To generate high-powered statistics is critical. And to provide for future multi-center grants where we can all work together on this is important. Now in the MS field, the Sylvia Laurie Center for Multiple Sclerosis does have a database that comes from several pharmaceutical studies, but not quite like what I'm talking about here. Reproducibility. Well, it will be important to see, can we get the same answers from different scanners at different sites? We've actually sent somebody all the way to China. They've been imaged twice in China, once in Canada, and twice in the United States, and all on the same piece of equipment. And the results are very reproducible today. These new systems of the 21st century are very well built, and so the potential to do those comparisons is possible. Do minor sequence parameter variations really matter? If I ran a particular sequence like a spin echo sequence and I slightly adjusted the echo time or slightly adjusted the flip angle, would it matter for my interpretation for MS? Probably not. So we need to define those type of parameters and how we could compare data across papers. And then, of course, as I said, imaging volunteers. What sequences could prove useful? Well, FLAIR and T2 for volume measurements and lesion load, T1 for pre and post contrast imaging to look at enhancing lesions and volume measurements, SWI for looking at iron content, abnormal veins, oxygen saturation, MRAV for the anatomical information you've seen presented here, either with 2D or 3D, and then flow quantification for functional information. So what do we think we could extract from such data mining? Anatomical variants of veins. We really need an atlas or a library of what the different variants are that have been seen today with the angiographic treatments and with MR. And I think this will be very important for us. If there are 20 different types of conditions for MS, and you really need good statistics, and you need roughly 50 per bin, that's 1,000 patients. However, you have to have that for every decade as well. So we have, a good 6 decades between 20 and 80, so now you're talking 6,000 patients. So you really need to have a lot of data to make conclusions here. Iron content as a function of age is another example. It would be much better if we had iron content mapped out from 20 to 80 with on the order of 20 cases per bin. That's 1,200 cases. Perfusion is a function of age. This is probably also very important. We know that perfusion does decrease as we get older. What are the different variations in local perfusion? I haven't really seen those results presented at this point in time. I just show you this as an example where we have several hundred cases here in a plot on the left-hand side showing the right common carotid artery, the left common carotid artery, and showing how these correlate with each other here. It's not quite a line of identity, but it's pretty tight. And these dark circles and filled-in symbols, they're all multiple sclerosis patients. And the green is normal volunteers. Now, in this case, I don't really expect any difference, and I would say in the hundreds of cases we've looked at, we really don't see a difference in terms of the arterial component, but in order to really demonstrate this, you'd like to plot it like this. How about if we look at the difference between this wonderful correlation on the arterial side, and we go to the right-hand image where we have a plot of the left internal jugular vein versus the right internal jugular vein? Well, my heavens, you can see quite a variation here. You can have people that have very high flow with the right and almost no flow with the left. And that can also be normal people, as you can see, as Robert mentioned here. Or you can have the opposite, of course. The question is there any pattern or recognition that you can take here to say there really is a difference? Now, these are plotting left versus right. It's not plotting total. Well, what we have found in that 2012 paper that Robert was referring to is that, in fact, very few normal people have flow in the jugulars less than 1/3 of the total venous outflow. Almost no normals do, but many MS patients do. And so do several other diseases that are associated with CCSVI. So to draw a strong conclusion, we're going to need a lot of data. What about the extraction of biomarkers? So is low total internal jugular venous flow important? How can I compare dementia, multiple sclerosis, Parkinson's disease, intracranial hypertension if I don't have 1,000 normal people? So I'm not interested in just imaging the disease. I'm very interested in imaging the normal population. What is normal iron? What can we do with these biomarkers to compare normal controls with MS patients or other patients? So we have in mind 3 projects. The first project I'm just calling the Centennial Project because it involves 100 normals and 100 MS cases, so that we can start by collecting that data and making the comparisons between the different modalities. Now, some of this work has been done by Robert and by others, but we want to establish a fixed protocol for doing that. We then want to do the same thing comparing the MR with the PTA, and again establish a fixed protocol with that. And once we have that fixed protocol, we want to go to the Millennium Project. And the idea behind this is to get at least 8 sites working together, all running exactly the same protocol, so that we can compare normal controls with any of these diseases we're interested in for CCSVI, including iron, vascular abnormalities, white matter abnormalities, and normal flows. So what are the criteria to participate in this project, which I'd like to call the International MRI Consortium Project, is to have a 3T scanner capable of doing the CCSVI protocol, to have an interest in sharing the data with other sites so that anyone involved in this protocol would have access to all the data on the database, The ability to recruit normal controls, somewhat like Joseph had said, where if you're going to image a patient and you can do the spouse, so you have people of similar age, of similar lifestyles, and a desire to collaborate, and an interest in participating in future multi-center clinical trials. So, in conclusion, I think it's critical for us to have a very careful acquisition method for normal controls, and I think one of the mistakes we've made in the last few years is not to have collected a few thousand normals. In order to convince the neurologists, you have to prove to them that the criteria or measures you want to use are really different between the patients and the normals. So this should be something that the NIH should fund or the European community should fund. It's absolutely critical for us to do normal people. This database should be made available to many people because things are so complicated in MR. Doing good volume rendering, for example, doing good perfusion analysis. If we collect this data, maybe the software we have today is not perfect. Maybe there are other softwares out there. Maybe there are 10 types of software to do volume analysis. Well, that data becomes available to all the groups who think they have the best method to do that, and then they can, of course, compare between these methods. The most advanced imaging methods should be used because we want this database to be valuable for the next 5 or 10 years. So we do want to have a very well-crafted protocol that can be used, maybe the second tier level that Joseph was mentioning, and we could have a different tier level for the normal clinical sites. Cost should be realistic associated with this. Luckily, many research sites have the capability to do this type of imaging much less expensive than clinical imaging, especially if we have some support from the NIH. So I strongly believe that we should be looking at grants to the MS societies for this, to other societies. And the most important thing is that access should be made available to all interested parties. So thank you very much.
Great ideas, Mark. As one who is participating in many, studies and trials in MS, I can tell you that really collection of the data without clear funding, it's extremely difficult because neither one of these sites can maintain, this protocol, whatever we establish that it is, over time. It's just impossible. Only way how you can, ensure that this is happening and it's transferred timely and it's occurring in a standardized manner is to, collaborate with the sites who are funded for doing that protocol. And everything what we tried and other people did just does not work. Now, in terms of, collection of the data, I think it's very important that maybe under the ISNVD umbrella, we begin to create a protocol that may be used and recommended by us to the other sites, both for the MRI portion of the brain as well as the MRV portion of the brain, and that we make, as you are suggesting, a centralized database for MRI collection, and then, to share this data and use this data for future analysis. However, it's critical to have healthy controls in this, and it's critical to also have, multimodal assessment of these outcomes. That's very, very important. I don't know if others are interested in this, but I think it's a great idea.
Thank you very much, Robert. I won't take more than about another 30 seconds here so we can move on. But I think you raise a very important point. We can't do thousands without some funding. But I think those sites who are interested, and let's say for argument's sake we come up with a white paper with a preferred MR protocol that can be used after the end of this meeting, that we go to these sites and we try to get something like 10 cases a site or something like this. Because in NIH, you won't stand a chance unless you have preliminary data. You're going to have to demonstrate that you can really do the same job across sites. But I think we could probably afford to do 10 or 20 normal volunteers in order to create this collaborative effort. So thank you for the encouragement. I'm glad that we have a possibility to go in this direction.
Can I ask you one more?
Joseph.
Hello. I have another question, Mark. You know, we've talked at this meeting a lot about different types of neurodegenerative disorders that may show indications or signs of CCSVI. And obviously we orient a lot of what we do towards the MS patient population, but as we know, and as you and I have seen, patients such as Parkinson's disease patients also show signs perhaps of CCSVI. I'd like you to comment on perhaps at what point and in what manner do we start mixing data sets between MS and Parkinson's towards looking at CCSVI in order to perhaps increase numbers or increase funding, and what are the positives in that and the negatives as well?
Well, I think CCSVI may actually be a fairly broad vascular disease and a broad name, because there's now evidence of exertional headache effects. There's evidence, as Dr. Zvadinov said, there's a number of other diseases. There's MS, there's Parkinson's, there's, I think the group from Taiwan here, Professor Huan Hu, has also other examples of this. I think all these diseases, even including dementia, are going to require the collection of normal data. So there's one other disease I didn't mention, and that's traumatic brain injury. Many of these different diseases actually can be done with almost the identical protocol we're talking about for MS. So the value of this could be argued, could have tremendous impact from the ISNBD's point of view, that these are all neurovascular diseases to some degree. So this is a project that if I were talking in front of a society for dementia, I would be just as enthusiastic as I am in front of this society that we should be doing this study. Thanks.
Thank you, Mark. As many, I'm sure of you, recognize this, Dr. Zamboni, and Dr. Zamboni is going to be talking to us regarding multimodality comparison of jugular entrapment syndrome. I'd like to take a moment to just thank you, Dr. Zamboni, for coming across the pond to see us here in America again.
Yes, 18 to. Thank you. Thank you very much. Okay. Thank you very much. Really, the situation seems to be unclear but clear. Screening by duplex is affected by operator dependency, however, demonstrated high specificity, low sensitivity, and mostly big variance among centers. Screening by MRV also demonstrates high specificity, low sensitivity. It seems no good for intraluminal defects detection, but highly reliable for collaterals. Catheter venography is invasive and likely not be the true gold standard. For example, I think that in somewhat way, the presence of a catheter may change the possibility to detect abnormalities clearly seen by ultrasound, for example. One question is IVUS the true gold standard? We need, however, a multimodalities approach and of specific protocols, as underlined also by Mark Haki. And also to develop new non-invasive, probably screening device. This is an example of IVUS, with respect to catheter venography. However, I think that imaging techniques need to know how to exactly image. CCSVI is a case of primary venous obstruction. It can be classified into three types: intraluminal defects, 2 is wall stenosis, 3 is external compression. The luminal defects include septum, malformed valve, and whatever was underlined today. Wall stenosis, segmental hypoplasia, twisting, double channels, and also agenesis that we found, and we are waiting for other investigating primary progressive. But unfortunately, catheter venography is always inserted on the right side, so we miss a lot of information. 3, external compression is bone compression, muscular entrapment. Oh. No. Okay. Okay, but yes. I was finishing that slide. No, don't worry. Okay, thank you. External compression is bone, muscular entrapment, and vascular nerve cracking. But I want to... Interluminal obstacles were very well depicted. We have a collection of postmortem studies very helpful in understanding the nature of this malformation. Valvular malformation, you may see very easily what is a valve. You may see that the jugular vein, the valve, and the sinus of the valve that is oriented toward the chest in order to prevent reflux from the chest. And one of malformation that we found is, for example, the presence of a tricuspidalic valve, like in this case, with, unfortunately, the lower leaflet that is oriented in the opposite direction, so prevent the good flow from the brain toward the chest. Also, other kind of valvular malformation, you may see a normal disposition of the leaflets, but also you may see a valve oriented on the lateral side of the vein wall. This looks a perfect valve for subclavian or for axillary vein, but not for the jugular vein. In fact, if you may see the specimen, the upper leaflets, when they is reached by the blood, is opened and create an intraluminal obstruction. Septum, you may see in this case a good agreement between catheter venography and high resolution B mode, but this is not always the case, because in the majority of cases, the catheter maintain artificially open the septum, and in this case, without ultrasound, you do not have a complete treatment. Wall stenosis includes something never seen before, like twisting, for example. This is a comparison between autoptic studies and the venography. But external compression show also element of normality. For example, jugular vein obstruction caused by turning of the head is a normal. It's not abnormal. You may see in this elegant study published about 30 years ago, one jugular is compressed, the other show a perfect flow. This kind of comparison, very well described by the Buffalo Group and Robert Zivadino, caught my attention, because you may see in a point between the sternocleidomastoid muscle and the carotid vein, there is a pinpoint, very, very little jugular vein, internal jugular vein, demonstrated with tricks and with MRI, MRV. And this is very interesting to me and caught my attention, because the majority of restenosis had this kind of appearance. So I began to study from the anatomy again, and I addressed my attention to the omohyoid muscle. You may see represent a superior belly and inferior belly, and between the two belly there is a tendon on a connective tissue in order to prevent the internal jugular vein from constricting under undue pressure. This was very interesting because exactly the point where Robert showed the pinpoint in his paper. This is a comparison between MRI and an anatomic table, and in green you may see the relationship between the omohyoid muscle and the jugular vein. Now look at different use of the ultrasound based on functionality. This is a jugular vein, seems wall stenosis. Asks to the patient to bite, and the stenosis is increased. Asks to the patient to open the mouth. Yawn. There is no stenosis. So you have rest, bite, and yawn. And this is an entrapment for the omohyoid muscle. Very common, probably more common that you may understand, but this cannot see, unfortunately, by catheter venography, and also cannot be demonstrated, certainly, by MRV. Sorry. This does not go forward. Okay. Next. The mouse, okay. But it's not changing. Okay. This is the operatory field. You may see very well what? The omohyoid inferior belly. You may see the compressed internal jugular vein. This was operated because of thrombosis, spontaneous thrombosis created by the compression. And this is the patent IGV in the cranial part, in the cranial segment. And you may see that in the limit between the inferior and the superior omohyoid belly, there is no connective tissue and tendon like I found in the catheter, but it's just muscle. So every time you have rest or bite, you have compression, undue compression and obstruction by external compression of the vein. Okay, few minutes, no, grazie. Strain gauge plethysmography will be presented more in detail. Could be a good system for screening. Fortunately, so okay, is really a tilt test, but I present this very well in the next days. What I want to show you is this rock curve, showing that this system shows a good sensitivity. And this is very important because we found a concordant rate of 75% by using just one parameter, and up to 83% by using 3 parameters. But the interesting thing is by combining this kind of modality with no imaging, it's just functional physiology, we have a good sensitivity, and after this you may use combination of duplex and MRV for increasing the specificity. I think that this could be probably a good advancement for multimodalities screening by including 2 different or 3 different systems to have good sensitivity, a good reproducibility, and perfect specificity like MRV and ultrasound. I'm sorry for what happened. I am available for questions. Thank you very much.
We have time for some questions. Paolo, thank you very much. Again, pushing the concept of multimodality. Do we have some questions from the audience? So, Paolo, you had mentioned that some things might not be possible with MR, such as visualizing what happens when you yawn or bite or something like this. In terms of getting flow data, if you could hold that yawn for 10 seconds, or if you could hold that bite for 10 seconds, then we could actually image this as a function of the cardiac cycle. But the huge advantage of ultrasound is, of course, you can image things real-time, millisecond by millisecond. So it is a tremendous advantage in doing that. But one of the things that the MR manufacturers would probably be very interested in your opinion, is what if you could take a trackball on an MR scanner and take a pencil beam, just like ultrasound, and you could just guide it in the MR scanner. So you could do your 3D acquisition, you could do your general flow acquisition, and then you come along and you say, okay, I want to now test what happens during a breath hold or test what happens during biting. Would this be something, and I mention this because, believe it or not, we did that 25 years ago, and then nobody used it, so it's all been lost to the culture at the moment. But today it should even be more viable to do this, that we can actually create a beam almost identical to ultrasound using MR, but nobody has that software. Is this important enough, maybe not just for MS, but you think for other applications in ultrasound, that if you're going to get an MR anyways, that maybe you could get the equivalent of the MR version of ultrasound? Is that something worth investigating?
Yes, we for example, used also an ultrasonographic system developed by GE that is called B-Flow, and is a technology quite similar to magnetic resonance, because you have a picture of a moment, and you may imaging all what is movement after that the first moment. So this is very useful to see the flow. And also I think that MR can be very useful in determining how much is the amount of blood in the collaterals. So just not imaging the collaterals very well with respect to ultrasounds, but to calculate exactly the volume of blood that is trapped into the collaterals. This, I think, could be very promising, because this is probably is a difference between normal individuals and people with problem in venous outflow from the brain. Because I suspect that the majority of blood volume stay trapped in the collaterals for longer time respect to normal people or respect to physiology in general.
Now that's very interesting, because sometimes you can see this when you do that with contrast agent, and we will often see, in fact, very similar to the comment you made about the catheter wire could, open up a septum. We've seen a case where we imaged the patient, and at the very end stage, even 2 minutes later, all the contrast should have been equilibrized throughout the body, but there was this long, bright signal still remaining in the left internal jugular. And when the IR went in to look at this, he couldn't find anything. And I think this is exactly what happened. And so you can actually see the stasis of the blood by following the contrast agent over time. Not quite the same as ultrasound, but still, I think it suggests that those people who are using this contrast-enhanced method, and similar to Joseph, what you showed, that these late phase images could be important.
There is another little comment. My suspect is if the diagnosis is limited to catheter venography, this is very dangerous. Also from the treatment point of view, because we may have down-treated patients. Because if you do not have any hemodynamic information by pre-op ultrasounds or something like, or by MRV, probably you may interpret it as normal venogram, something that represents some intraluminal obstacle or something like this, cannot be properly seen preoperatively, and we may have down-treated patients. This is very important also for interventionalists. There is a current of interventionalists who consider useless MRV and ultrasound assessment before the operation. This is not good. Also because you do not have any chance to control the patient a long time after the treatment. So this is very important. For example, plethysmography is very important because we may have a quantification base, but also MRV, and may give us some baseline of flow quantification, and this is very important to control the patients a long time.
Thank you very much, Paolo. So just before we adjourn here, I would like to remind you that we have then the 8:30 breakout sessions tomorrow, and the goal behind this is to help prepare the three moderators who are Raj Atariwala and Salvatore Sclafani and Nicholas Liasis to help guide that, because they have to present their data at 10:30 based on what they will have presented now and the discussions that take place. And our goal here for the Society is to really produce 2 more white papers, one on MR, one on PTA, and then maybe update the ultrasound one. I think we can have a big impact by doing that. And of course I have the selfish interest of IMRIC in doing this, but I think it will be important for all of us. Also, for those of you who are speaking tomorrow, it's very important that you get your slides to us first thing in the morning, if possible, so that everything can be set up at the back here ahead of time. So particularly Raj and Sal and Nicholas, we need yours right away. And if Kirsty Duncan is here, for her as well, and Jack Burks. So generally speaking, have your modifications ahead of time to us. We actually have every talk from you that was delivered a month ago. The problem is you're all changing them. So if you can give us the new version that morning, it will make it a lot easier to make sure that you have the correct talk here. Thank you very much, everyone, and see you tomorrow.